Good morning, everybody. My name is Dr. Rhonda Bell, and it's my pleasure to talk to you today about weight and food changes in participants in the APrON cohort. Before I get going, I'd like to thank all of the participants, all of our funders, and my colleagues who have helped with many of these analyses that I'm going to talk about today. Without all of you, this would not have been possible. Non-communicable diseases such as cancer, diabetes, cardiovascular disease, and mental health disorders are the leading causes of deaths worldwide. They contribute to more than 50% of the global burden of disease. Non-communicable diseases impact everybody, and it's growing rapidly in all age groups, at all income levels, and in all regions of the world. APrON has always operated from a developmental origins of health and disease perspective, which is built on a strong body of evidence showing that preventing chronic diseases starts by optimizing health and health behaviors before and during pregnancy. This helps to ensure that children are born with the lowest possible risk of chronic disease and sets them up for the best health outcomes in childhood, adolescence, adulthood, and older age. Because it starts before and during pregnancy, it also helps to improve the risk for future generations. We need studies like APrON that follow people forward to really understand how to best support people to have their healthiest start in life possible across generations. In today's first talk, you heard about the extensive amount of information that APrON participants provided to the project. In this talk, I'm going to focus on some of the first data that was available from women, namely that of her body weight and height, as well as her diet before, during, and after pregnancy. This slide shows some of the participants' characteristics of women who were in the APrON cohort during and after pregnancy. Women in APrON were in their early 30s when this study started. Most had stable partners, had completed university, had a high income, and who had been born in Canada. They had babies who were born at term, around 39 weeks gestation, with a birth weight of about 3,300 grams or just over 7 pounds. The first thing I'm going to focus on today are women's body weight changes during and after pregnancy. Pregnancy-related weight change was and is a hot topic. This is because women's weight changes in pregnancy are used as a simple way to help track mother and baby's health throughout pregnancy. Weight gains that are lower or higher than expected are associated with pregnancy complications. So if weight gains are in either of these categories, this can be cause for further follow-up. In 2010, Health Canada released updated guidelines for healthy pregnancy weight gain. In this, they specified both lower and upper ranges for weight gain according to pre-pregnancy BMI. APrON participants provided the very first prospective information in Canada about how weight changes in pregnancy in contemporary women. In this graph, we have the results of women's adherence to the weight gain guidelines at the end of their pregnancy. On the x-axis, we have pre-pregnancy BMI, and on the y-axis is the percentage of women in each of the categories. The different colors of blue and green indicate whether women were below, met, or exceeded the gestational weight gain guidelines. For simplicity's sake, I'm going to direct your attention to the total cohort results, which is at the far right-hand side of this screen. What you can see is that for all women in APrON, about 20% of them gained below the guidelines, about 1/3 of them met the gestational weight gain guidelines, and about 50% of them exceeded the gestational weight gain guidelines. This then paints a picture that gestational weight gain is a public health concern in Alberta, both in terms of excess and of lower weight gain. This data and information has been replicated now many times by many cohorts worldwide. In fact, there are over 200 publications that come out with almost the exact same proportions of women who were either below, meeting, or exceeding gestational weight gain guidelines. We've gone on to look at this data in many other ways. Here we see the weight gain trajectories of women who had different starting BMI at the start of pregnancy. The top panel are those who were in the normal weight BMI category. The middle panel are those who were overweight before pregnancy, and those in the lower panel are those who were obese before pregnancy. What we can see from each of these trajectories is that women who were heavier to start off with gained in excess of the guidelines at an earlier point in this pregnancy. This really emphasizes the importance of having conversations about gestational weight gain early in pregnancy. This slide shows changes in women's body mass index at 3 months postpartum. On the x-axis, we see women's pre-pregnancy BMI according to whether they were underweight, normal weight, overweight, or obese. The x-axis is further subdivided into whether women were either below, met, or above the gestational weight gain guidelines. On the y-axis is the proportion of women, and the different colors on the bars represent the category, the BMI category that women were in after pregnancy. So again, whether they were now underweight, normal weight, overweight, or obese. If we take an example and look at women who started pregnancy in the normal weight category but gained above gestational weight gain guidelines, we can see that about 60% of them returned to the normal weight category after pregnancy. About 38% of them moved up one BMI category to being overweight after pregnancy, and about 2% of them moved up 2 categories to being in the obese category after pregnancy. For those women who were overweight, about 1% of them moved down a category to being normal weight. About 60% of them remained in their overweight category as they had started, and about 40% of them moved up a category to being in the obese category after pregnancy. In fact, there was a 2.6 times higher likelihood of women moving up a BMI category if they gained in excess of the gestational weight gain guidelines. These results have been replicated in several studies, and it appears that these changes in BMI, so this extra BMI weight retention, lasts for between 2 and 20 years. In summary, about 50% of women in APrON gained in excess of the gestational weight gain guidelines. That excess gestational weight gain was evident by between 18 and 33 weeks of gestation, and it was earlier for women who started pregnancy with a higher BMI. Excess gestational weight gain was also related to higher rates of weight retention in the postpartum period, and about 20% of women gained less weight than is recommended. Since this information was known from APrON by about 2015, we've since partnered with Alberta Health Services to help support women having healthy weight gain in pregnancy and weight loss after delivery. There's been many things that have come out of this partnership, but some of them I'm going to highlight here. This is an example of a digital ad campaign that was aimed at raising awareness of weight gain recommendations that women saw or hopefully saw early in pregnancy. There were also a number of tools developed, such as this online pregnancy weight gain calculator, and there were posters for physicians' offices and printed materials for women. There was also a series of learning modules prepared for healthcare providers to help them learn how to discuss pregnancy weight changes, pregnancy-related weight changes in respectful ways with all women, and how to measure and discuss weight starting early in pregnancy and into the postpartum period. Now I'm going to shift gears a little bit and move into looking at our information on food intake before and during pregnancy. Women in APrON answered many questions about their diet, and for that we are all eternally grateful. When it comes to analyzing dietary information, there are 2 basic ways to look at this data. One is what's called food patterns, which looks at the foods that are consumed and in what combinations they're consumed. The other is looking at nutrient data in each of the foods consumed. Today, I'm going to focus on the food patterns piece of this story. Women in APrON completed a quite long questionnaire asking about the foods that they ate in the year before they became pregnant. What we learned from this analysis was that women who consumed a healthy dietary pattern before pregnancy had a reduced risk of developing hypertension in pregnancy. That healthy pattern was characterized by regular intake of eggs, healthy oils, fish, pasta and rice, fruit and vegetables, and lean meats. Very similar patterns are now being supported in the new Canada's Food Guide. Women are asked to complete a 24-hour dietary recall during each of their study visits. We developed a way to analyze this data by comparing that information to the recommendations outlined in the 2007 version of Canada's Food Guide. This slide shows the 4 food groups in the 2007 version of the Food Guide and the specific recommendations for each of these food groups. During pregnancy, there were 9 food-related recommendations. 8 are also for non-pregnant women, and 1 recommendation is specifically for pregnancy, and it suggests that women can consume 2 to 3 extra servings per day from any food group. Between 30 and 56% of women met the different food-based recommendations that were in Canada's Food Guide. Less than 1% of women consumed the extra servings from any food group. To calculate our Canada's Food Guide score, we gave 1 point for meeting each recommendation, so the highest possible score was 9 if someone met all of the recommendations. Nobody actually got a score of 9. The average Canada's Food Guide score was 3.2 out of 9, which suggests that even among highly educated women who face few barriers to healthy eating, there's still room for improving the quality of their diet. We took a different approach to evaluate the intake of less healthy foods, and that's because there is no recommendation for consuming less healthy foods. The recommendations have been to limit their intake. What we did here was we categorized each less healthy food eaten by women into one of 8 different categories, and the categories are shown on the bottom part of this slide. So things like soft drinks, potato chips and salty snacks, desserts, pancakes, waffles, and hot chocolate. What we did was we looked at the distribution of how frequently women ate foods from each of these categories, and we gave her a score according to where she fell in the distribution for each of the food groups, and then we added up all the scores for every woman. The best score would have been 0, and they would not have consumed any less healthy foods. No women got a 0. The highest score would have been 24, and that would have meant that the person consumed in the highest tertile for each category. The average score was 3.4 out of 24, which again suggests that women are eating some, but not too many, less healthy foods. Overall, APrON women who had healthy food patterns before pregnancy had lower risk of an important complication, namely gestational hypertension. About 30 to 56% met some of the dietary recommendations outlined in Canada's Food Guide, and all reported consuming some less healthy foods, although not in great quantities. APrON women represent a best case scenario, and this work suggests that we need to work on how to best support healthy eating in pregnancy. In conclusion, APrON is the most thorough description of women's nutrition and weight before, during, and after pregnancy available in Canada. This information is not available anywhere else and is unique in the world in many ways. It has been highly influential in helping us to understand where the strengths and gaps are in women's eating, nutrition, and body weight changes in pregnancy. There's a lot more to the story to come, and some of that will be in the next talk. But in the meantime, I'm happy to answer any questions. Thank you.